Welcome everyone, and welcome to a recording on thyroid adenomas and thyroid cancer. So starting with the follicular adenoma, which is the most common type of adenoma, this is just a benign proliferation of follicles. And most of the time, the follicular adenoma is non-functioning, which means it's not actually secreting excess thyroid hormone. So on your radionucleotide iodine scan, you will show a cold nodule. In terms of on a molecular level, it's not 100% sure how follicular adenomas come about, but there is lots of studies on the effect of the TSH receptor and how there might be constitutive activation of the TSH receptor, meaning that there is a proliferation of follicles as a result. Macroscopically, the follicular adenoma is normally very solitary, very well rounded, very well circumscribed. And on microscopy, you will be able to see a dense proliferation of follicles. So if you actually look under a microscope, you will still be able to see follicles, but they will be a lot more dense and there'll be a lot more hypercellularity as well. The cells are well differentiated, and around the adenoma is a well circumscribed capsule. And this is the hallmark of the follicular adenoma, because if that capsule is breached, it then becomes a follicular carcinoma. Unfortunately, when you're doing your fine needle aspiration, which is one of the main diagnostic processes of a lump in the thyroid, you can't actually get the full amount of the adenoma, so you can't really tell whether it's been breached or not. So whether you treat something as a cancer or an adenoma is purely based on clinical suspicion. Patients will obviously just present with a nodule on their thyroid. In certain circumstances, they may be thyrotoxicosis, but most of the time, as we said, it's a cold nodule. The prognosis for a patient with a follicular adenoma is very, very good. Moving on now to thyroid cancer. Now there are four main types of thyroid cancer: papillary thyroid cancer, follicular thyroid cancer, Anaplastic thyroid cancer, and medullary thyroid cancer as well. So we'll start off with the most common thyroid cancer, and that is our papillary thyroid cancer, with over 85% of thyroid cancer cases coming from the papillary thyroid cancer division. So one of the most important things about papillary thyroid cancer is what causes it, and there's a huge correlation between papillary thyroid cancer and radiation in childhood. And this is associated with a BRAF mutation. And these two things, radiation in childhood and the BRAF mutation, are normally high yield things on board questions. So if you have a presentation of a young adult with a mass on the thyroid or a confirmed thyroid cancer, and you found out they had a lymphoma back when they were a child, or they had some kind of head and neck cancer and they required radiotherapy for it, then you will know this question might be leading towards the papillary thyroid cancer diagnosis. Macroscopically, most of the papillary thyroid cancers are well circumscribed, but there are cases where they might be more infiltrative and not so well defined. And on our cut surface, which is if you cut the cancer in half, you might be able to see papillary foci and even areas of fibrosis and calcification. Now, the microscopic findings for papillary thyroid cancer are very, very important and very, very high yield for board questions. So the nuclei have got central clearing, which creates this sort of opaque appearance at the center of the cell. And these are referred to as orphan Annie eyes. I would suggest you search up pictures of these so you can get a good look into what they look like. And also, you see papillary structures as well. So these are why the thyroid cancer is called papillary thyroid cancer. And you will be able to see fibrovascular cores inside these papillary structures. Around the papillary structures, you will also be able to see samamabodies, which are concentric calcified matter within the structures. And the third finding is things called nuclear grooves, which are these sort of elongated longitudinal nuclei that you can see in some of the cells. So if somebody says biopsy of someone's thyroid cancer, you can see these orphan eyes with central clearing of the nuclei, these concentrically calcified like nodules, these samama bodies, and some nuclear grooves, then you know this is definitely your papillary thyroid cancer. Clinically, the patient will present with a painless neck mass, and there can be metastasis to the cervical lymph nodes. There is a lymph metastasis. And the prognosis for these patients, again, is very, very good. Most thyroid cancers are, but if the patient is above 40 years old, or if there is extra thyroid spread, then this can be associated with a worse prognosis. Moving on now to the second most common thyroid cancer, which is your follicular thyroid cancer. Now, this type of thyroid cancer is slightly higher in women, and it's actually mainly due to people who have had an iodine deficiency. People with iodine deficiencies tend to have a high TSH over time, and this can cause neoplastic changes in the thyroid gland itself. It is also associated with a RAS mutation as well, and this is something that is often seen in board questions. The main differential diagnosis for a follicular cancer is, of course, your follicular adenoma. And remember, when we were talking about the follicular adenoma, we said if that capsule is breached, it becomes the follicular cancer. That's why we need to do routine checking of these nodules. Macroscopically, they're normally very well defined. There can be more infiltrative and invasive types with foci of hemorrhage and more lobular appearances. But microscopically, it's very, very similar to the follicular adenoma. Uniformed follicles, but just a little bit more dense than normal thyroid tissue. And as I've said many, many times, the capsule will be broken. Most of the time, even though they are follicles, normally the nodules are cold, meaning they're not producing thyroid hormone. And another huge difference of the follicular carcinoma compared to the papillary carcinoma is that its spread metastatically is via blood. So it's a hematogenous metastasis, and it commonly spreads to the lung, the bone, and the liver. Again, like papillary thyroid cancer, the prognosis of this cancer is very good. Moving on now to our third thyroid cancer, and this is the anaplastic carcinoma. And this is one of the thyroid cancers that has got a poor prognosis, and it's mainly seen in old people. So there are two features of the anaplastic carcinoma that kind of separates it from the other types. It's mainly seen in old people, and it's got a poor prognosis. In fact, there are many reports that a lot of these patients who have the anaplastic carcinoma have actually got a history of previous well-differentiated cancers that have now become undifferentiated over time. One of the normal, very special features of the anaplastic thyroid cancer is its rate of growth. Patients normally present with a rapid enlarging of this nodule, and it will be commonly invading into the adjacent structures. So what are the adjacent structures? Well, it could be invading into the trachea and causing a respiratory compromisation. It can invade into the recurrent laryngeal nerves that are around that area. That can cause a hoarseness. And it can also invade into the esophagus as well and cause dysphagia. And the USMLE commonly uses this as a question to test your anatomy. Microscopically, you'll be seeing clumps of anaplastic and really poorly differentiated cells. And for people more keen on the pathology of this, they often find spindle cells and also these pleomorphic giant cells. And pathologists often describe it as osteoclast-like cells because of their giant cell appearance. And of course, you won't be seeing many follicles, so you can rule out a follicular carcinoma. And you won't be seeing these papillary structures, so you can rule out a papillary carcinoma too. In terms of metastasis, they normally metastasize to the lung fairly early on, which is why this cancer has a poor prognosis. And unfortunately, normally after 1 year after diagnosis, the patient will have passed away. Another main differential diagnosis for anaplastic thyroid cancer is Radel's thyroiditis, which I have discussed in a previous recording. If you recall, Radel's thyroiditis presented with a really hard as a wood nodule on the thyroid gland, and again, it often spreads very quickly and invades local structures. So some ways that can help you differentiate between the two. If it's a young patient, normally they're presenting with Radel's thyroiditis. If it's an older patient, normally they're probably presenting with an anaplastic thyroid cancer. But the important thing to know is the only way you can actually diagnose between the two is via a biopsy. The final cancer that we're going to be discussing is the medullary thyroid cancer, and this doesn't come from the parenchyma of the follicles, it actually comes from the parafollicular cells. And if you remember your physiology, you'll remember these are the C cells that produce calcitonin, and calcitonin will lower your blood calcium. So you probably already have an idea of clinically what you might be seeing in this patient. The medullary thyroid cancer is very much associated with the multiple endocrine neoplasia 2 syndromes. So this will be your MEN 2A and 2B. And this is normally due to a RET mutation. And this is very high yield for the board exams. So if you have a patient presenting with a neck mass, likely a thyroid cancer of some form, and they also have a history of pheochromocytomas, you might be thinking, this is probably a MEN syndrome. Also, to refresh your memories, people with the MEN 2A syndrome likely have parathyroid adenomas as well, and patients with the MEN 2B will often have those oral ganglioneuromas. So always make sure to look at the question carefully to see whether those cancers that they also have can correspond with a syndrome. The microscopy of medullary thyroid cancer is very high yield for the board exams. So you will have these nests of malignant parafollicular cells, and then in between you have this amyloid stroma, which is essentially these collections of calcitonin. And the immunohistochemistry stain for these amyloid stromas will be calcitonin, so it will stain calcitonin positive. And also, because it's amyloid, you can also stain it with Congo-RET as well. So how does this patient normally present? Well, they're normally going to have a neck mass, so they could have dysphagia and hoarseness potentially, but also they're going to have high calcitonin levels in the blood, which normally means they're going to have hypocalcemia. So again, always look out for a patient with a neck mass and low calcium. Just to finish, I'm just going to mention a couple of ways of how to investigate and diagnose people with thyroid cancer. A lot of it is based on taking a detailed history and doing a good endocrine and thyroid examination. The blood tests will be able to tell you whether the TSH, the T3 and T4 are elevated or depressed. As I said, most of the times in adenomas and cancers, the thyroid hormone is actually normal. The patient is in a euthyroidic state. So if a patient does come with a mass on the thyroid, then you can take a TSH and T3 and T4 levels, and if they are normal, this should raise some suspicion that it could be a cancer. Ultrasounds are a good non-invasive alternative to biopsying, but ultimately, to get a definitive diagnosis of the thyroid cancer types that we've been discussing, you're going to need to do a biopsy, which is done by a fine needle aspiration, so you can get a detailed look of the histological findings. Most thyroid cancers are seen in young people and they have got a good prognosis, with the anaplastic thyroid cancer being the exception to that. So I have a quick question for you. A 74-year-old man presents with a neck mass that has been progressing rapidly. He experienced some dysphagia about a month ago and is now, over the past 24 hours, experienced some hoarseness. Which of the following nerves is most likely compromised in this patient? So you're quite right, it's the recurrent laryngeal nerve. I know that's more of an anatomy question, but it's kind of just showing you how they can relate some of these pathologies to the anatomy. And we did discuss how the recurrent laryngeal nerve is often compromised in patients with expanding thyroid cancers, such as the anaplastic thyroid cancer.